Hello and welcome. I'm your host, Neil Howard. Thank you so much for joining us for another segment of Health Professional Radio. In this segment, we'll be speaking with Dr. Theresa Hadlock. She's joining us here from Mass Eye and Ear and also from Harvard Medical School to discuss her research on facial, plastic, and reconstructive surgery controversies in facial reanimation. Welcome to Health Professional Radio, Dr. Hadlock.
Thank you so much for having me. Really appreciate the opportunity.
Glad that you could take the time. Tell us a bit about yourself and your position at both Mass Eye and Ear and at Harvard Medical School.
Well, I have been in the Harvard system for the past 30 years, 25 of them as an attending facial plastic and reconstructive surgery. So facial plastic and reconstructive surgery encompasses the entire gamut from cosmetic procedures to reconstructive procedures to highly specialized repair of very specific facial defects. And most of my professional effort has really been focused on that latter area where I focus almost exclusively on facial reanimation, that is restoring movement and function to the paralyzed face. With respect to Harvard Medical School, that is really the academic home for physicians within the Harvard teaching hospitals. And so I have, for many years, I ran a research laboratory where we conducted translational research. And over the past some years, my research has focused more toward outcomes and patient satisfaction following different kinds of reconstructive procedures. So that's really where I'm focused right now.
Now, I mentioned that you were going to talk about one of your presentations, facial plastic reconstructive surgery controversies in facial reanimation. Where was this data presented?
So we presented what we called the Great Debate down at the annual Otolaryngology Academy meetings in Philadelphia last month, and it was intended to highlight some of the controversies in facial reanimation surgery. So it was two experts taking opposite viewpoints of how to approach specific clinical scenarios in facial paralysis. But the neat thing that we did was that the two of us, I did this with Professor Kofi Bohaney, who's also a facial plastic and reconstructive surgeon, but down at Johns Hopkins. He and I took opposing views, and then we switched our viewpoints so that we each adopted the view of the other. The real essence of the presentation was to highlight the fact that there really aren't hard, fast rights and wrongs in how to approach this very difficult reconstructive entity. So I think that is really what we meant by highlighting the controversies.
Well, explain to us what the relationship is between reconstructive surgery and facial reanimation and why it's so controversial.
I would say facial reanimation surgery fits into facial reconstructive surgery, but facial reconstruction fits more within the larger picture of facial plastic and reconstructive surgery, which is a continuum all the way from purely aesthetic surgery, like an aesthetic rhinoplasty or an aesthetic upper lid blepharoplasty or an aesthetic facelift, all the way to massive facial reconstruction, let's say including face transplantation for the severely disfigured face. So the idea is that facial reanimation is a subject that encompasses both aesthetic elements and reconstructive elements. People are disfigured by the inability to move one side of the face, and that doesn't look appealing to the naive observer. But in addition, they have functional deficits, which our reconstructive procedures are designed to resolve.
Are the procedures the same when it's paralysis due to injury or if it's paralysis due to some type of disease?
That's a little bit of a complex question, but the short answer is yes. For example, so many clinical scenarios result in permanent, long-standing paralysis. You can be born with that. You can develop that as a consequence of a brain tumor many years earlier, or of the resection, or from the resection of a head and neck cancer. And all of those clinical scenarios demand one single reconstructive procedure to restore movement. Mm-hmm. Having said that, there are basically two flavors of facial paralysis: a flaccid facial paralysis, where the face is collapsed and atrophied, and then there's hypertonic facial paralysis, which is the type of thing that we see after Bell's palsy, Ramsay-Hunt syndrome, Lyme disease, and those faces are like too tight. So in the too loose face, there are a lot of tools we can use, and in the too tight face, there are different and sometimes overlapping tools that we can use. So it's not as much a question of the etiology as the prognosis, the natural history, and which bucket the patient fits in, flaccid or hypertonic.
What are some of the most common facial reconstructive surgeries that you see in your practice, in your experience?
Well, I would say that the most common condition that we treat is Bell's palsy. And that is not to say that we treat people who experience a brief episode of facial weakness followed by rapid recovery and essentially normal movement. But we treat poorly recovered Bell's palsy or prolonged Bell's palsy in which patients suffer that state of hypertonicity, and they require what we call downgrading procedures, denervation, the removal of some inappropriate nerve branches or muscle that is too tight or muscle that is antagonistic to the smile. Aside from that, I do a great deal of free tissue transfer, that is to say, transplanting a muscle, usually from the inner thigh, into the face to restore facial movement in the permanently paralyzed face. And that really doesn't come from one specific condition, but rather a rather lengthy list of multiple conditions that result in that. Head and neck cancer is something that's extremely frequently seen in my offices, along with conditions like head trauma that result in temporal bone fractures that cause facial damage. So lots and lots of, we have a very high volume center here. So if it causes a facial movement disorder, we usually have seen it.
You said that you and your colleague had opposing viewpoints on reconstructive and reanimation surgeries, and then you adopted each other's viewpoints. What is the major controversy when it comes to differing viewpoints and some of the other major takeaways from the presentation?
I have to say that there are no really burning, heated controversies, mostly because it remains a rare problem around which we continue to actively innovate. So really the controversies are micro controversies. Mm-hmm. How do we sew this nerve to that nerve in the most effective way? Mm-hmm. Which location is best for the placement of cross-face nerve grafts? When do we initiate physical therapy and rehabilitation for these spaces? Where exactly do we place an eyelid weight? There are micro controversies mm-hmm. that add up to a lot of debate. The reason that we presented this at the Academy was to illustrate to the audience, to the learners there, that there are many, many unanswered questions with respect to facial reanimation, and to really spur them to become part of finding the answers to whether one approach is superior to the other through effective clinical and translational research.
Is there anything that you'd like to add for our listeners, and then give us a website where we can learn more?
I think the take-home message from controversies in facial paralysis is simply to say that, as I just stated, there are so many things that we really don't know about the very best ways to treat this condition. I have made it my life's work to try and elucidate some of those answers. And my greatest hope is that we can galvanize the community of starting clinicians and mid-career physicians to embrace the culture of outcomes assessment so that we can all start thinking about the problem in similar terms and really determining which things are best for our patients. And this population is a tremendously afflicted population, and any difference that we can make really is so impactful. So if you'd like to learn more, is some information on our website at www.masspioneer.org, and I would welcome any listeners to go there for further information.
Dr. Hadlock, I appreciate your time this morning. Thank you so much for joining us here on Health Professional Radio.
It's a pleasure. Thank you very much.
You've been listening to Health Professional Radio. I'm your host, Neil Howard, in conversation with Dr. Theresa Hadlock. Audio copies of this program are available at hpr.fm and healthprofessionalradio.com.au. You can also subscribe and listen in at Anchor, Spotify, and be sure and subscribe to our YouTube channel at youtube.com/Health Professional Radio.